Good afternoon and welcome to today's IAC webinar, ASE Guidelines and IAC Standards for Quality in the Echo Lab. My name is Kelly Bear and I'm the Creative Design Manager with Marketing Communications at IAC. And with that said, I will now turn this webinar over to today's speaker, Katherine Gibson, IAC Director of Accreditation for Echocardiography. Katie?
Thanks, Kelly. Today's objectives are going to be to discuss quality improvement methodology in the United States. We're going to describe the requirements for a quality improvement program in an IAC-accredited echo facility, and then I'm going to provide you with some tips on how to implement a QI program within your echo lab. So we have a lot of information to cover today. Some of it you may know already. Hopefully you come away learning some new tip that you can implement, but let's go ahead and get started. In 2001, the Committee on Quality of Healthcare in America at the Institute of Medicine in Washington, D.C., published a report with 6 aims for improvement. They recommended that healthcare should be patient-centered. This is providing provision of care that is respectful and responsive to patient preferences and needs, ensuring that patient values guide clinical decisions. Patient-centered care should, of course, be safe, with avoidance of injuries to patients from the care that's intended to help them. Patient-centered care is effective, with provision of services based on scientific knowledge to all who can benefit, not providing services to those not likely to benefit. We want our patient-centered care to be timely, with reduction of waits and harmful delays for both the patients who receive the care and those who give the care. Certainly, we would like our patient-centered care to be efficient, with avoidance of waste, including waste of equipment, supplies, ideas, and energy. And finally, we need our patient-centered care to be equitable. This is provision of care that does not vary in quality with respect to gender, ethnicity, geographic location, and socioeconomic status, or some other personal characteristic. Typically, safety and effectiveness are the most commonly addressed metrics. However, all quality aims are important for patient-centered care. These principles set forth a specific direction for policymakers, healthcare leaders, clinicians, regulators, purchasers, and of course others to improve the U.S. healthcare system. So, how do we implement these quality aims in the Echo Lab? Well, in 2006, Douglas et al. Proposed a model for achieving quality in cardiovascular imaging consisting of 4 distinct domains of process that affect clinical outcome. This starts with patient selection, image acquisition, image interpretation, and results communication. Elements of the laboratory structure, including your equipment, staffing, protocols, and your infrastructure, influence these and also support these 4 process domains. The first phase of assessing quality is to ensure appropriate patient selection or look at the appropriateness of the test that's ordered. You should ask yourself, how will the exam affect medical decision-making, and will it lead to a quantifiable patient benefit? Next is image acquisition. So you should be reviewing the equipment. Is it well functioning? Are our technical staff members proficient? Are our imaging protocols complete? And do they meet current standards and guidelines? And also, very important, can a facility safely obtain a diagnostic quality image optimized for each individual patient? Following image acquisition is image interpretation. Is the diagnostic criteria adhered to when documenting pathology? Is their report free of inconsistencies? And of course, most importantly, is it interpreted accurately? Finally, test results must be communicated to referring physicians in a complete, clear, clinically relevant, and timely manner to optimize our patient's treatment. The American Society of Echocardiography published recommendations for quality echocardiography laboratory operations in 2011 with the intent to provide a framework for our quality assessment and improvement within the Echo Lab. Their goal was to highlight general recommendations for minimum quality standards, focusing on the process of clinical echocardiography, including our Echo Lab structure and imaging process. Referencing Douglas et al., ASE states, imaging process can be further separated into 5 areas that may influence patient outcomes. They include patient selection, image acquisition, image interpretation, results of communication, and then they add the incorporation of results into care. In all of these domains, we do have distinct benchmarks of quality that can be established. ASE states that the Echo Lab structure can be divided into a minimum of 4 components, and then goes on to provide recommendations for each. The physical laboratory, including lab operations, policies, and physical attributes of the lab. The equipment, which includes, but it's not limited to, imaging capabilities of the ultrasound system, and of course, preventative maintenance. The sonographer, this is including recommendations for credentialing and education requirements. And then the physician, including recommendations for training and competencies and certification. When breaking down the imaging process into the 5 mentioned areas, ASE recommends for patient selection that Echo Lab should ensure that all staff understand the appropriate use criteria, develop processes to reduce the number of inappropriate referrals, and this would include the education of referring physicians, and actively apply appropriate use criteria to selected procedures. Image acquisition in echocardiography relies on a variety of components, including but not limited to patient conditions, equipment, competency and technical manipulation of the ultrasound system, and consistent methods of acquisition. Echocardiography image interpretation must include assessment of all cardiac structures, function, and performance of all measurements when technically feasible. The interpretation should also include a summary of the findings relative to the indication for the examination. Components for results communication include key elements for reporting the interpretation, amending the report when necessary, timeliness of the report, and reporting of critical results. All echocardiographic reports should follow a uniform outline. If an amendment is made to a report that results in any substantial change, then the summary should describe any action that's been taken. Studies should be categorized as stat or routine. Stat or urgent studies should be interpreted and communicated immediately. Routine studies should be interpreted within 1 business day. So each Echo Lab should have a policy for reporting critical values and a method to communicate these findings. Echocardiographers may aim to develop and implement strategies to educate their referring providers about what an echo can and cannot measure, when to use it, and what findings mean for both diagnostic and therapeutic decision-making. ASE then goes on to make recommendations for quality assessment and implementation of a quality improvement program, where quarterly assessments are done to evaluate the quality of image acquisition, image interpretation, and results communication. And finally, the ASE also recommends that Echo Labs should be accredited by the Intersocietal Accreditation Commission, or the IAC. By doing so, a facility is provided with the framework to adhere to established standards in echocardiography, as well as the tools to implement a continuous quality improvement program. As part of Echo Lab accreditation by the IAC, a facility must develop a policy for quality improvement of all imaging procedures, which includes quarterly assessments and biannual QI meetings. So the IAC requires the following measures to be evaluated. We're going to go into a little detail about each one of these. First would be test appropriateness. Currently, this is required for adult echocardiography only. Pediatric echo, it's not required to review test appropriateness. However, it should still be done. Perioperative TEE accreditation requires that there is a policy for verification of indication. So when you're looking at test appropriateness, you're asking yourself, is there any reason why I shouldn't be doing this test? Did the patient have the same test yesterday and they have no change in clinical status? Is there a more appropriate test that should be ordered for this patient? All sorts of questions you can ask when reviewing for test appropriateness. Next would be technical quality review. This is sometimes known as the sonographer's performance variability. A technical quality review is looking at image acquisition. Were all of the images obtained? Was the protocol followed? Is my technical quality good? Should I have used ultrasound enhancing agent? Should I have adjusted my color box? Is my depth too low or too high? I want everybody to keep in mind that during a TEE, whether this is adult, pediatric, or perioperative TEE, the sonographer in this case is the physician. So please make sure that you are doing a technical quality review of your TEEs as well. Next is interpretive quality review. This is also known as the physician's interpretation variability. This is an overall review of the interpretive quality of your report. Was there any comments made that are not correct? Did we omit a positive finding? Was there an inconsistency within the report, a comment that didn't match something in the summary? Next would be final report completeness and timeliness. This is two separate metrics. Report completeness is a review of whether or not the report included all of the required measurements, text comments, a summary of the comments, any reported critical findings, anyone that you talked to about the findings of a stat or an urgent study. And then report timeliness is the overall turnaround time. Was the report finalized in the required amount of time? Finally, IAC recommends routine correlation and confirmation of results with other imaging or diagnostic modalities in adult echo. However, this is still a requirement for pediatric echo lab accreditation. We'll get a little bit into correlation later. For IAC accreditation, a minimum of 2 cases per modality that you would be applying in, modalities being broken up into transthoracic, TEE, stress echo, adult congenital transthoracic, fetal echo, or perioperative TEE. So minimum of 2 cases per each of those modalities must be evaluated. You can use the same cases for all of the required measures. If you're part of a big multi-site accreditation, you must evaluate each site at least once a year, and we'll give you some tips on how to do that as well. The facility must have a minimum of 2 quality improvement meetings per year, and that's a bare minimum. One of which of these is to review all the results of your quality improvement analyses and any additional QI-related topics. All staff must participate in at least one of these meetings per year. Finally, the IAC program also requires that your QI documentation includes, but not limited to, the data for all of our quality improvement measures, minutes from all of our quality improvement meetings, and of course a participant list, which includes remote participation or any review of meeting minutes. The QI documentation must be maintained and available for all appropriate personnel to review. So now you're asking yourself, how do I put this all together? Where do I start? So when you're implementing your quality improvement policy, you want to identify a quality gap. So first, you're going to need to perform a self-assessment of your current practices. When thinking about quality improvement, we want to make sure that this is just a method of continuously examining the process and making that more effective. The focus should not be on any one individual. It should be fully on the process. Quality improvement should not be punitive or demeaning. We're not meant to divide our echo lab. We certainly do not want this to be busy work. There should be intent behind what we're doing. So here are some rules for quality improvement. Keep it simple and practical. Involve lots of people and ideas. The more minds sharing in the QI process, the more opportunities for improvement will be identified. Steal shamelessly from others. I know that sounds funny. If you're stealing ideas from other groups, it sounds negative, but it's not. If you've heard of another facility identifying something that's changed patient management, you might want to try to implement that same QI project within your facility as well. But definitely adapt what you've stolen to your practice. So you may be a smaller facility than someone else, or you could maybe not see the same patient population as they do. But so certainly take somebody else's good idea and use it for your own. Just adapt it to what is meant for your practice. Definitely be methodical in your documentation. You want to make sure you have clear, concise documentation for QI so everyone can follow along if you make a change. And if you're stealing from people, you should also share with them. So share what you found. You can submit things to journals. You can talk about it on a webinar, but share the information because who knows what patient that this could help in another state, another country. The requirements for a successful quality improvement program, it does start from the top down. You first have to have full leadership commitment. So this comes from your medical director and your technical director. This is very important for a successful quality improvement program. If they have not committed to it, then what is everybody else doing? Next would be a commitment of resources. This could be as small as once a quarter blocking off a couple patients so your technical director can do their quality improvement. This next, you could commit resources. Maybe you enroll in some sort of registry, or you hire a full-time person to be your quality manager. There are lots of different ways, different resources out there, but those are just some examples. And finally, an individual commitment. Everyone needs to be committed to the process. So if you've been asked to do a peer review, don't hem and haw over it. Just do the peer review. You're probably asking, okay, you've given me some tips, but does IAC offer anything to help me out? Well, it does. We offer the QI self-assessment tool. This can be used by any facility that creates an account with IAC. So if you're already an accredited facility, you have access to this all the time. The tool helps you review and evaluate your lab studies and reports for all of the IAC required QI measures in adult echocardiography. So we're missing correlation, but I have something else for that. So for pediatric echo labs, correlation is something else we have. It also creates a report that helps to identify any opportunities for improvement by providing a data-driven objective measure of your QI progress, including compliance with IAC standards and individual facility quality initiatives. The purpose of the QI self-assessment tool is to educate your facility on how to perform a self-assessment or peer review of cases, recognize any deficiencies, and then implement a corrective action or a process improvement plan when deficiencies are identified. The QI self-assessment tool has 3 simple parts: selecting your cases, reviewing the cases, and then an assessment summary report. Many of you have probably used the QI tool. If you're already part of an IAC-accredited facility, you've probably taken it at least for a test drive. We are going to go into a brief overview of the how-tos. This may help some of you if you've had questions about it. I'm also, throughout this part, I'm going to provide some tips and best practices when using the QI tool. So for those of you who are brand new to it, though, once you're ready to start, you're going to navigate to that quality improvement tab, which is within your online portal here. I'm going to pull up the laser pointer. This quality improvement tab. You're going to click on that, and then you're going to come down here and click Create New Assessment. Next, you're going to enter any identifying information for your case studies you wish to review. You're going to click on Enter Cases. When getting started, I suggest you choose cases that cover a wide variety of performing sonographers and interpreting physicians. But of course, try to choose case studies randomly. But I have another caveat. You should also aim to only evaluate complete echocardiograms to establish an accurate baseline. The questions are set up to review complete exams. So if you come across a limited study, you're not necessarily going to get an accurate score, I guess I should say, because the question may ask about a view that isn't typically done in that limited protocol. So it'll say no, and it'll give you a score based on that. So this is why you should aim to evaluate only complete echocardiograms with the QI tool. So when you're entering your cases, you can enter up to 30 case studies in each assessment. You don't have to enter 30. You can just do the bare minimum of 2 per testing area. For each case study, you're going to enter patient initials, so the first 3 of the first name, first 3 of the last, the exam date, and the case type, who performed it and who interpreted it. For case type in adult echo, you have the option to choose for adult transthoracic, a general case, so just any old transthoracic. You can choose adult transthoracic with aortic stenosis or adult transthoracic with LV regional wall motion abnormalities. And then the questions will change based on the specific case type. You will also have the option to provide any additional identifying information. That's totally up to you. Your next step is to assign staff to review the cases. So when you click on that assign staff, you'll enter in some information as to who you want to review it. That staff member must be listed as a QI user in your account or an admin user. We can talk more about that later. Or if you have a question about it, you can let us know. I suggest assigning multiple reviewers for each case because the more peer reviewers you have looking at the same case, the more likely you will be to uncover opportunities for improvement. Finally, well, not finally, but after you've assigned your staff cases to review, each peer reviewer is going to receive a notification via email when they've been assigned a case to review. They're going to log into the online account and go to review my cases. The reviewer will then be prompted to answer a series of questions for each case that they are assigned to. The questions cover the quality measures that we talked about for appropriate use, technical quality, interpretive quality, and report timeliness and completeness. There are also spaces for overall comments in each section, which is very helpful. So now that we've looked at a few examples of how a reviewer would assess some of the questions, well, now we're going to look at a few examples of how a reviewer would assess some of the questions. So this case may be likely to come through an adult echo lab. Great example, someone we've probably all seen. We have a 56-year-old male with a known bicuspid aortic valve. They had an echo 10 years ago at another facility. So last time they ever had an echo. So the question that first pops up in the QI tool is, with the clinical information provided, was the test ordered for an appropriate indication? So while the evaluation of test appropriateness is not a requirement for IAC pediatric echo accreditation, it is always important to evaluate. Therefore, we opted to include this in the QI tool assessment as well. So if you're a patient, if this is a patient coming through the pediatric echo lab for some reason, you would still see this question. So we've been given our clinical information, and then the answers to our question are, is this an appropriate indication for an echo? Maybe it's appropriate, or rarely appropriate, or not usually appropriate. So how do we assess test appropriateness? Well, we use our resources. We go to our appropriate use guidelines. There's a multi-organizational appropriate use criteria for multimodality imaging and valvular heart disease. Transthoracic echo, we go down to try to find our appropriate indication, and we see that transthoracic echo is appropriate for routine surveillance every 3 to 5 years for a patient with stage A bicuspid aortic valve or aortic sclerosis for exclusion of progression to stage B. So this known bicuspid aortic valve with an echo 10 years ago, this is appropriate to do an echo on this patient. This is another question that's likely to come through an IAC-accredited adult echo lab. And the QI tool, like I mentioned, has specific questions specific to evaluating adult echocardiograms that are showing aortic stenosis. So we have a study here that contained these 2 Doppler tracings alone, just these 2, with the non-imaging transducer. And I know it's hard to see the labels right here, but they are both obtained from the apical position. So the QI tool is going to ask the question, Was the aortic valve velocity acquired using a dedicated continuous wave transducer in at least 2 standard views? Then your answers would be yes or no. So let's look at the standard. The answer to the question is no, because the standard states for aortic stenosis, the systolic velocity must be evaluated from multiple transducer positions. This would be apical, suprasternal, and right peristernal. This must include interrogation from those multiple positions with the dedicated non-imaging continuous wave Doppler transducer, and you must obtain at least 1 clear envelope. So while they took 2 beautiful image tracings from the apical position, they were not from multiple transducer positions. So they needed to document something from the right sternal border and or the suprasternal notch. All right, our next review question is for our pediatric facilities, but this will be a good refresher for some of our adult as well. This question is going to pop up on our pediatric QI tool. So the indication for the test, we have a patient who is 1-month-old female that has a murmur. The patient's older sibling has a history of bicuspid aortic valve and coarctation of the aorta. The question that will pop up that we're going to look at here is, are the ascending, transverse, and descending aorta with definition of arch-sidedness demonstrated? I can see that this is kind of a multi-part question. So we're given this study and only this image of the aortic arch in 2D was given to us in the study. So let's look at the question. Are the ascending, well, here's the ascending, transverse, yep, and descending aorta, okay, with the definition of arch-sidedness demonstrated? Well, our arch is pointing to the left in this picture, so do we say yes? The answer is no. The ascending, transverse, and descending aorta were demonstrated in that image. However, arch-sidedness was not demonstrated. So this is actually a separate picture. Arch-sidedness must be documented to rule out all of our aortic arch anomalies. From your suprasternal notch position, you're going to turn the transducer to have it oriented at 3 o'clock. So that's like a short axis. You're going to sweep superiorly up towards the patient's head. And you're going to follow the course and branching of the first vessel that arises from the aorta. So this guy right here, and you see it goes off to the patient's right and breaks into 2. So I know it goes a little fast, off to the right side of the patient and breaks into 2 vessels. So that is our brachiocephalic artery going into the subclavian and the right carotid. So we know that the arch part is pointing to the left of the patient. So this is a left aortic arch with normal branching. And this is how we demonstrated arch-sidedness. Okay, now we're going to focus on interpretive quality. One objective measure of interpretive quality is to look for internal inconsistencies within our report. Let's go over what internal inconsistencies are, because this is still a big confusing thing for our accredited labs, and we see it pop up a lot. So an internal inconsistency is a 2D and or M mode measurement that is not in agreement with our text comments. This could be Z-scores as well. So in our PEDS labs, if you have a Z-score of -5 and you're saying that for the aortic annulus and that's normal, that would be an internal inconsistency. It's -5 would be very small. Other ways, you're saying that the LV wall thickness is normal, but all the measurements in the report are measuring outside of your normal values. So that is an internal inconsistency. Next, you would have conflicting statements within your final report. In the text summary, you free texted that the LV function was moderately reduced, but down in the findings section, you texted a comment that said that it was mildly reduced. So that's a conflicting statement within the report. Why is this important? Certainly it can cause confusion, but more importantly, incorrect information is being sent to our referring physicians or the patient's chart, or if you're utilizing any sort of registry or structured reporting, data mapping, anything like that, it's going to pull conflicting information. It's probably going to pull stuff from your structured report and not your text comments. So this is why this is important. You want to have accurate data. So here's our next example. We have another 4-month-old with a murmur. And the summary states, it says impressions, but this was the summary of this report. So we're going to focus here on these bullet points. We have moderate pulmonary valve stenosis with trivial insufficiency. We have a trivial patent ductus arteriosus with left to right shunting. Mild RVH with preserved function, otherwise structurally and functionally normal heart with caveats under findings, and no pericardial effusion. So I can see they probably free texted this. I'm not sure that this is something that comes in your structured report, but that's something you would want to consider. So since they said there's caveats under findings, let's take a look at the findings. So let's just focus on two things. The semilunar valve section. So up at the top, we said there was moderate pulmonary valve stenosis with trivial insufficiency. So here we say, let's go to the pulmonic valve. We have a doming pulmonic valve leaflets. We have normal pulmonic valve annulus. There's physiologic pulmonic valve insufficiency and moderate pulmonic stenosis. Someone may argue that physiologic is not the same as trivial. So that might be something that you and your medical director might want to discuss, terminology, making sure that you're on the same page there. But next, I want you to take a look down at the ductus arteriosus. So here we said there was no patent ductus arteriosus detected, but up here we said there was a trivial PDA with left to right shunting. In most cases, your referring physician is going to take a look here, but we really want to make sure we know which one is actually correct. Was it this free text here, or was it this here? Is it possible that your sonographer prepared a worksheet for you and they didn't think they saw a PDA, but the doctor did? So this is an area of opportunity for improvement to make sure everybody's on the same page. Moving on to report completeness and timeliness. Just again, keep in mind this is two separate metrics. When looking at your report completeness, you're going to determine whether or not all relevant comments, measurements, and demographic data were included, and ask yourself if this report includes a summary of the findings that were relevant to the indication for the test. Report timeliness. Make sure you are looking at our IAC standards for specific turnaround time requirements. Your facility may have a higher benchmark than we do, and that's okay too. So just as long as you're at least meeting the minimum IAC standard required amount of time, you're in good shape. So was that report generated in the IAC standard required amount of time? If you need assistance with that, we can show you where to find that in the standards. Okay, so once all of our reviewers have looked at our cases and they've been completed in the assessment, you're now going to be able to view a report. For each case within the assessment, the report shows a breakdown of responses to each and every question, and then it scores each question based on these responses. So for our first case, we have an adult transesophageal echo, and it was reviewed by 3 staff members, we see. We have 2 staff members that said that this was an appropriate indication for this test. And we have 1 staff member said that, I don't know if this was appropriate. I'm not sure if we should have done it. And they put, text comments here, which is helpful. So here's an opportunity for us to discuss, this facility to discuss appropriate use criteria when it comes to this indication, whatever the indication was for this test. For our technical quality, we have some variability on how the reviewers answered the question, are the apical views foreshortened? So we have 1 person who said yes, they were, and we had 2 people who say no, they were not. So this may be an opportunity to look at the case together and do some education on what foreshortened images actually look like. For interpretive quality, I'm going to point out that there is this nice little opt-out answer for our sonographers who are doing interpretive quality review or shouldn't be doing it, or you have a policy against them doing it. It says, I am not a physician and do not assess interpretive accuracy. We don't have any standards against sonographers doing this. So if you have an advanced cardiac sonographer or it's just you, the sonographer, and 1 physician, it is okay for you to review interpretive quality. However, if you're one of these sonographers that select this, we want to make sure that you have a physician review 2 cases for interpretive quality to make sure that you're meeting the IAC-QI requirements. As you can see from this example, we only had one person assigned to this case to assess, and they chose that answer. So this case was not evaluated for interpretive quality, and we can tell that because there's no score here. There's no checkbox, there's no X. So if you're doing this, make sure interpretive quality is being assessed in another way by your physician, or more probably easier, just assign it to a physician and a sonographer every time. And here's some samples of our pediatric QI tool questions to assess report completeness and timeliness. They're pretty similar to the adult transthoracic as well. We have some questions like, did the final report include an indication for the study? And then as for our turnaround time, we have this, was the final report generated within the required amount of time? If you don't know what the required amount of time is, you can click right on this link here and it'll take you right to the standard. So that's a helpful feature for the QI tool. And as always, there's a place for text comments. If there's something that you saw that was missing from the report that's not listed in the questions, put it in the text comments. Each case in our assessment is scored in terms of overall case quality and level of agreement among staff members. So this is where I said it is important to put multiple people on the same case for assessment, because look at our test appropriateness score. We have a 67% agreement. So there's lots of confusion over whether or not some of these tests should have been done. So this is a really great area for opportunity for improvements, where this facility should focus their first QI improvement goal. So keep in mind, again, that you want to assign this to as many people as possible. Lots of opportunities for education here. And finally, the tool will give us a nice little visual to help us determine where we should focus our first quality improvement goal. So let's take a look at this one for quality. Our other facility should have focused on appropriate use, but this one, we want them to look at the interpretive quality review. That's the lowest score we have. 89 is not terrible, but it is the lowest score, so that's where we should focus our first goal. I know we talked about correlation very briefly, so what about it? It's not only an excellent learning tool, but it is essential to multi-modality team approach to patient-centered care. So for our pediatric facilities, we must be performing correlation with any appropriate imaging modality, surgical finding, or clinical outcome for a minimum of 4 cases a year, with at least 2 cases per relevant testing area to be reviewed in your QI meeting minutes. So if you're only applying in pediatric transthoracic, you would do 4 transthoracic cases. But if you're doing pediatric and TEE, or pediatric or transthoracic and TEE, or transthoracic and fetal, you can do 2 of each. And that's the bare minimum. Some of our recommendations for correlation, and this would go across not just pediatric, but for adult as well, for patients who have undergone a transthoracic echo or some other diagnostic procedure like a cath or an MRI. If they've had surgical intervention, or if you're performing a post-mortem exam, the results of our transthoracic echo and that other procedure should be compared routinely. Same thing goes for TEE. You may want to focus on comparing our studies in regard to valvular abnormalities, LV function, and abnormalities of the aorta. And then when you're doing fetal echo, for patients who've undergone a fetal echo and then some other diagnostic procedure, most likely your postnatal echo, a cath, or an angiogram, postmortem if necessary. These results of our fetal echoes and other procedures should definitely be compared with regard to the accuracy of the fetal echo. So this gives you a really great learning opportunity. Correlation data for each physician responsible for interpreting and or performing the echocardiogram in your facility should be accumulated by your facility and distributed to those interpreting physicians. So everybody should, have access to their own performance. Statistics should be generated to ascertain the overall accuracy of echocardiograms being performed in the facility. So if you hold those statistics and you map them over time, you should be able to see improvement as you've been making changes. And any process for addressing discrepancies between the echo exam results and results of other procedures should be in place. So I know the QI tool doesn't have a correlation part in it, but there are several ways you can keep track of your correlation documentation. Some people use spreadsheets. Every time a fetal is done, they track the due date, and then they follow up with the postnatal echo and compare the results. Some facilities will do that with transthoracics that show wall motion abnormalities or stress echoes that go to cath. But IAC also has a little correlation worksheet to help you organize your data, and this can be downloaded from our website. Okay, what's next? Did you observe an area with a particularly low quality or agreement score? So I know we said we were going to focus on that interpretive quality score. So that's what we saw in the previous graph. So this is a great area to start with. I think everybody's probably seen this SMART goal, maybe at an HR meeting or something like that, but we've identified our first goal, and that's to raise our interpretive quality score. So let's use that acronym SMART. First, we're going to be specific and clearly state what the goal is. So we had an 89% interpretive quality score. We'd like to raise that to 92. That's our specific goal. Our quality goal next needs to be measurable. So using the QI tool is a great way to measure your progress once a change has been implemented. So what you could do is you could start reviewing a sample of reports from every doctor, kind of narrow down who is who may be using free text. Are we seeing a lot of internal inconsistencies, or is something not mapping over correctly? So the goals, of course, need to be achievable within your scope and possible to accomplish. So I think going from 89 to 92 is achievable. And quality goals should absolutely be relevant to your specific echo lab. You don't want to do something totally lofty if it doesn't make any sense. And then you're going to be specific on your time frame for accomplishing this goal. We would like to have 92% within the next quarter. That could be, maybe a little lofty. Maybe your next is within the next 6 months. So whatever your time goal is. Next, you're going to talk to each other, because you're going to open the lines of communication and help build a culture of quality within your echo lab. So no one should be afraid to speak up when they find an area for improvement, but also don't be afraid or resentful of constructive feedback. This is essential to quality patient-centered care. No room for ego. Everyone must get along. So now that we've built our goal, we can start the PDSA cycle. So this is something else you've all probably seen before, but let's go through it. So PDSA stands for Plan, Do, Study, Act. Start by planning. You're going to be objective with the evaluation of your QI tool results in developing a plan of implementing a small change at first. This is going to include identification of who will be responsible, what the change will be, where and when it will take place, and over what time period. So we already said during our SMART goal what we were going to do. We're going to make our medical director and technical director be in charge of this. They're going to evaluate a sampling of cases from each physician every Friday for 4 weeks. And then we're going to do that for 4 weeks. We're going to carry out this plan. So over the next 4 weeks, they're going to collect their data, document their experience, document any problems, document any surprises. Like I said, it could just be something's not mapping over correctly. And then after that, you study or analyze your data and compare to what you had predicted as the outcome. Maybe you didn't predict anything, but you still need to look at your data. So did something unexpected happen? What conclusions can you draw from this test? Because data measures whether the change is due to chance or not. So you may need to reconsider. Maybe you didn't find anything different. Maybe it was just a fluke. Last month was 89, but this month it's excellent. So you may need to reconsider what you're doing or sustain or extend your process improvement. Finally, you're going to act upon it. This may include refining your process, modifying your plan for the next cycle. If they didn't find any changes or if they didn't find anything wrong, Maybe it's just to have education and talk to each other. Another benefit of the QI tool is that it has an analytics that can help you track your progress over time. So as you act or refine your process or modify your plan, you have an easy way to track your progress. So you can filter this between months. You can pick, if you just want to look at the metric for technical quality or interpretive quality in this, you can also pick a specific case type that you want to track. And then this will give you track your progress. It looks like they've been pretty stable. This group kind of does the same stuff over and over. So there's always room for improvement, though. So maybe they want to take a look at their technical quality score next. You may have a series of PDSA cycles that will lead you from your baseline to your goal. Don't be discouraged about this. Change does not happen overnight. We all know this. Sometimes it's hard to get people on board. Echo labs should strive to continuously improve their quality and always look for areas for improvement. I'm going to give you some fun tips, additional quality improvement best practices. I've said it a million times, involve everybody. Just involve everybody. It'll make life easier for everyone. And one way you can do that for our large multiple sites, we have some facilities that have set up QI teams, and they rotate their assignments. So maybe you have 4 or 5 different sites where you have different sonographers and different doctors at each site. So you set up quarterly, you have a representative from each site perform assessments. And in this way, you're kind of breaking up the work. You're only required to do a peer review once a year instead of once a quarter. So that might make your doctors happy. And here's some outside of the box thinking things. We've seen a lot of facilities do some of these practices. So these are real life examples. Maybe you want to consider building some flags within your reporting system. So you could do daily QI. This could be as simple as, you're looking at a pediatric study that didn't correlate with the previous. You got a higher gradient last time, but not this time. So that could be an opportunity for QI. Build a centralized location for record keeping. This doesn't just have to be for large multi-sites, but it is certainly helpful for them. We have seen some facilities build a SharePoint site where they've put all of their QI minutes. They've built like daily QI blogs. They will send out our quality improvement quiz from the SharePoint site. We do a monthly quiz. Play along with that. That's been a lot of fun, but they'll link it right to their site. And they'll also put in videos, things like that. And speaking of videos, make videos. If you have found a setting on a machine at your site, or if you found a setting on a machine that's really helpful, maybe for bringing in, coronary color flow, if you're looking at coronary arteries in pediatrics, or you found that there's a nice penetration setting for some of your big patients, or you found a really cool way to utilize contrast that you make it better, you've optimized it, make a video, post it to your SharePoint site. Consider sending a periodic quality update focusing on any practice issues. This could be as simple as sending an email or a memo. Incentivize the QI process. So QI doesn't just have to be about technical quality. It could be about lab operations. For example, we have a facility who incentivized cleaning the machines. At the end of each month, they will, take their logs, and however many times you were the person cleaning a machine, you may throw your name in a bucket. And at the end of the month, they will pull somebody's name out of the bucket and they get a gift card to get a coffee. So, we've incentivized our quality improvement. Keeping our machines clean is good quality for the patients. Also utilize other resources. There's tons of resources out there. You don't have to just use the QI tool. And one of those resources is the Image Guide Echo Registry. So ASE and IAC have collaborated to build a report within your Image Guide Echo Registry dashboard that you can view accreditation-specific data. And this is reflecting report completeness and timeliness measures. So IAC will also accept this specific registry report as the documentation for that required QI metric. For more information about the registry, certainly reach out to ASE. They're great to work with. They can help you with all your questions on that end. If you're utilizing the registry and you have questions as to how to submit some of that stuff to us, or if you're looking to build a big QI project using some of those metrics, give us a call and we can help you figure that out as well. So in summary, quality can be improved by looking at the work performed, how it is done, how it can be done better. The focus should always be on the process and not the individual. Open communication and willingness to accept constructive feedback are going to help build a culture of quality within your patient-centered care in your echo lab. All right, thank you.
Okay, thank you, Katie. And at this time, we will begin the Q&A session. From IAC Echo, I'd like to introduce Allison Josephson, our clinical specialist, assisting with the Q&A session today. Allison, would you like to start us off?
Thank you. Yes, we have several questions that are related to QI that are really good. And one that came in is the use of the IAC QI tool required?
That is a great question. Use of the QI tool is not required for IAC accreditation. It is simply a tool that is built to help you assess your quality improvement. As I mentioned, it is used in many of our audit activities, so you may want to at least take it for a test drive at the bare minimum. But I would say take it for a test drive anyway, just to see if it's something you can implement within your facility. But no, not required at this time.
Excellent. Next question is, who can I assign case studies to for review?
Ooh, that's also a good question. Anybody within your facility that you want to. I would say at the bare minimum, assign cases to your medical director and technical director. It may just be the two of you, and that's okay. A medical director can do a review of their own case studies. And, it's always nice to take a step back and do an overread. Yes, sonographers, as I mentioned, can review interpretive quality as well, but they do have that opt-out answer. Other things that you can do with this is add your trainees. So if you've hired a new sonographer, make them a QI user and use this tool to evaluate their progress within their training period. This will help them understand where you're coming from too. So a great way to teach someone how to do a review of their own work and also provide them with feedback that's objective. Another thing you can do is use this for your fellows. This will help teach them to do a review of their own work, but also the review of looking at the images. You're just training them on how to interpret things. So you can add anybody. By doing that, though, you have to make them each a QI user within your account portal. So it's hard to visualize this without the pictures, so we can walk you through it if you have questions. But this is done through your account portal under the Manage Users tab. You're going to enter some information about them and make them a QI user. You don't need to have everybody have admin access. So if you just want them to review cases, you create a QI user. And like I said, give us a call if you need help with adding them, or if you have questions about how to utilize this with trainees or fellows.
All right. Here's another good question that came in is, my doctors still like to do our QI process on paper. Is that still okay? Because it's just easier for our lab to go with that.
Yes, that is still okay. If that's what works best for your facility and that is how you're getting everybody to accomplish their QI, absolutely use paper.
All right. Next question. Can we use the IAC maintenance of certification process to fulfill our QI requirements?
Ooh, really good question. So the maintenance certification process, for those of you who don't know, ABIM has created where you can get mock points or maintenance of certification points to maintain their certification. IAC has a program where you can enroll your physicians in that. And what they'll do is they use the QI tool to assess excuse me, 10 patients every quarter throughout a year. So I will say you can use this documentation with the caveat that as part of that maintenance and certification process, your physician is only allowed to document review of cases for the same testing modality all year. So if you're applying in, let's say, adult transthoracic and adult stress, your doctor is only reviewing adult transthoracic, you're going to have to do something else to supplement the stress echo quality review. So if you have more than one doctor enrolled in your maintenance of certification process, you can assign one doctor to do transthoracic and one to do stress. And then that way you have both of those done. But that's also not really involving everybody. So a way that you can involve everybody in the lab is have some of those doctors do the maintenance of certification program, and then have your sonographers review some of the same cases and make those be presented at QI meetings. So you have more of a variability score there. So if you have more questions on how to implement that, or if you're interested in the maintenance of certification program, please let us know. And we can give you some more tips on how to do that, how to incorporate both. But it is technically outside, separate from your accreditation data, but you can utilize that as long as all the testing modalities that you're applying in are evaluated in some way. Good question.
Got another good question in here. If our lab is utilizing other resources like the registry or the American College of Cardiology's QNED, do we also need to evaluate an additional 2 studies per modality for IAC purposes?
Ooh, another very good question. You can absolutely use any resources that are out there to document your quality improvement. And you can use it towards IAC accreditation as long as you can prove to us that each of those 4 metrics or 5 in pediatrics case are being evaluated on a minimum of 2 cases per modality. So let's just take the ASE registry, for example. So the registry, right at this time, that report in your dashboard only reviews report timeliness and completeness. So when you're looking at that, that's only one piece. You're going to have to supplement some of the other stuff in some other way. So if you can use the registry data to create some sort of QI project for other things, but make sure you're supplementing everything. As long as you can prove to us that whatever you're doing outside is reviewing all 4 of those metrics, then no, you do not have to do anything separate. All right, Allison, I think we have time for probably one more good question.
All right. Okay, well, last question. IAC used to have QI questions on the website. Where did they go?
Ooh, that is a good question. We took them down. The reason why we took them down was they were outdated. We are encouraging everyone to use the QI tool if they don't have some other process in place. Using the QI tool, we update it regularly as the standards are updated. And it's, save some trees. Don't print stuff out if you can. I know I said you can use paper, but, if you have your own forms that you've created, great. But we got rid of the ones that are on the website. So if you're still feeling a little shy about the QI tool, let us know and we'll help you through it. It's very easy to use. All right, I'm going to turn it back over to Kelly. Thank you for the great questions, everyone. If you have more questions, please let us know. You can reach out to us anytime. But I'm going to turn it back over to Kelly so she can tell you how to get your credits.
Hey, great. Thanks, Katie and Allison, and thanks again, everyone. Please feel free to contact IAC with any questions that were not answered during the Q&A session. Once again, we thank you for joining us today and appreciate your participation.